Thank you for joining us and welcome to the workshop session, Top 3 Nutrition Abstracts. I'm Elizabeth Reed from the Children's Hospital of Philadelphia and will be introducing today's speakers. My co-moderator, Judy Fulton from Children's Hospital Colorado in Denver, is working hard behind the scenes to gather and organize your questions. Just to review how to ask questions today, on the right-hand side of the screen, you'll see the text box with the separate tabs for chat and Q&A. Please submit your questions in the Q&A tab and feel free to chat socially throughout the presentation in the chat tab. Only the questions entered into Q&A will reach the speakers and moderators for consideration. This nutrition workshop session will include abstract presentations on findings from the PROMISE study, the FIRST study, and the GALAXY study. Each presentation will be 10 minutes, followed by 5 minutes for discussion. I'd like to introduce our first speaker, Dr. Sarah Jane Swartzenberg, Professor of Pediatrics, University of Minnesota.
Good afternoon, and I thank the moderators for allowing me to present this information today. Oh dear. I have nothing, these are my disclosures. Gastrointestinal disease is a central feature of cystic fibrosis and affects nearly every organ that we consider to be part of the gastrointestinal tract. It results in chronic abdominal pain in many people, diminished quality of life, and in many, poor growth or poor capacity to maintain weight. As part of the PROMISE study, the GI PROMISE section evaluates the impact of elexacaftor, tezacaftor, ivacaftor on gastrointestinal symptom frequency and severity, health-related quality of life related to GI wellness, intestinal inflammation and absorption from the intestine, both non-pancreatic and pancreatic. As you know, this is an observational prospective cohort study at 56 US centers in the CFF-TDN, and the eligibility is people with CF greater than 12 years of age who have at least one F508del allele and are initiating ETI therapy. To measure abdominal symptoms, we are using the patient-reported outcomes studied in the GALAXY study. We are measuring PAC-SIM, which is a patient assessment of constipation symptoms, the PAGI-SIM, a patient assessment of upper gastrointestinal symptoms, and the PAC-QOL, a patient self-administered questionnaire to assess quality of life in the lower gastrointestinal disorders. We're also using the Bristol Stool Scale, fecal calprotectin, and fecal elastase 1. In this study, all patients serve as their own controls. The results for the baseline data, which was accumulated prior to starting ETI, and results at 1 and 6 months time points are presented. At baseline, 438 participants had completed at least one of our patient-reported outcomes measures, and 120 had fecal data. The participants were evenly distributed across age groups, including 12 to 18 years, 18 to 30, and 30 plus. The participants were evenly distributed by sex at birth. The majority were white, and 49% were modulator naive. I'm going to take just a minute with this table, as it is a baseline for the tables that we're going to use in the next few slides. This represents the changes from baseline in the PAGI-SIM, which questions upper GI symptoms. As you can see on the left, there is the total PAGI-SIM score, and below it, the different domains of the PAGI-SIM. The red dotted lines represent the responses at baseline before starting ETI. And the black dots represent the results that as a change from baseline at 1 month 3 months, and 6 months after starting ETI. Moving to the left of the red dotted line indicates improvement in symptoms. Moving to the right of the red dotted line indicates worsening of symptoms. As you can see, we have slight improvement in symptoms in most areas of upper GI symptomatology, except for the domain of bloating. And at 6 months, that is slightly worse. I'll also mention at this point that in general, a change of 0.5 in PAGI-SIM is considered significant, and none of these changes reach that level. To better understand the worsening of bloating after start of ETI, we broke down these results by sex at birth. The blue dots are males and the pink dots are females. As you can see in bloating, females did have a small improvement in the symptom of bloating, but males actually worsened during the administration of ETI. At this point, we don't fully understand this, but we're looking forward to data at a year to see whether this continues or worsens. These are the changes from baseline in the PAC-SIM, the lower gastrointestinal symptoms. Again, the total score and domains on the left. And as you can see, again, there are small deviations from the baseline at 1 month, 3 months, and 6 months, but not large ones. Similarly, changes in baseline in the quality of life related to lower GI symptoms. Again, domains on the left, and small improvements without reaching a level that we would think would be clinically significant. We also looked at the Bristol Stool Scale at baseline and at 1 month. You can see here that the bottom 2 lines are actually the most informative, where between baseline and 1 month, we saw an increase in diarrhea and an increase in an alteration between diarrhea and constipation. This is similar to many of the anecdotal reports that we've gotten about the start of ETI, suggesting that people do develop diarrhea when at the beginning. Fecal elastase, which is a measure of pancreatic sufficiency, did not differ between baseline and 1 month. The patients who had mild, moderate, or severe fecal elastase levels at baseline had them at 1 month as well. Fecal steatocrit, a measure of fat in the stool, also did not vary between baseline and 1 month. However, fecal calprotectin, which may be a measure of inflammation in the intestine, did decline between baseline and 1 month, similar to what's been seen in studies of ivacaftor. In conclusion, after 1 month of highly effective modulator therapy, fecal calprotectin, which may reflect intestinal inflammation, was decreased. There was no change in fecal elastase 1. After 6 months of ETI, there were no substantial changes in gastrointestinal symptoms from baseline, although for most things there seemed to be a small improvement. We speculate that ETI, while it may lead to improvement in lung function fairly quickly, may have less or a delayed impact on gastrointestinal symptoms in people with cystic fibrosis. I'd like to acknowledge my co-investigators on the GI Promise sub-study, the 56 TDN centers that are enrolling and following patients, and of course the core Promise team, which you see up there. Thank you.
Thank you, Dr. Schwarzenberg. We look forward to every result from this study. Did males gain more weight than females?
I cannot answer that. That is part of a separate presentation, and I cannot remember those results.
Do you know if there was any contribution from a relative lowering of enzyme dose with weight gain causing more of the bloating?
I do not know that. There's no, I don't even believe we have that data to know that.
Okay. And why do you think you did not see a change in the fecal elastase over a month?
That's an interesting question. These are older people. They're above the age of 12. It is possible that they simply do not have the capacity to have their pancreatic function restored. But I want to point out that in the studies of ivacaftor, we saw improvement in pancreatic function for a very long time after we started ivacaftor. In the Kiwi and Climb study, people were improving. These, of course, were children. They were, I believe, 2 to 5 years of age. But their improvement in fecal elastase continued to increase over the full 84 weeks of the Climb study. So I'm very hopeful always for the 6-month and 1-year data from the PROMISE study. We're not going to call it quits yet.
We're all looking forward to that data. And when will we be hearing more updates on this topic from the PROMISE study?
I think fairly soon. We do have the 6-month samples. We simply could not get them run in time for this meeting. So I think we'll hear soon.
Okay, well, thank you very much. And we certainly will look forward to more results.
Thank you.
I'd like to introduce our next speaker. Dr. Lai is a professor in nutritional sciences, pediatrics, and population health sciences at the University of Wisconsin-Madison. The ultimate goal of her research is to develop personalized nutrition therapy and evidence-based clinical practice guidelines to improve clinical care and health outcomes of children with cystic fibrosis. Dr. Lai?
Thank you, Judy and Liz, for inviting me to present in this workshop. Today, I'm going to share with you our initial data on gut microbiome and intestinal inflammation that are generated from the first cohort. The only disclosures I have are from grant funding agencies that support the first study. Just a very brief background. We all know that gut microbiota plays a significant yet largely unexplored role in humans across the lifespan. In the field of CF, there are no large cohort longitudinal studies that have characterized gut microbiota in the first 6 years of life in children with CF, with concurrent comparisons to their siblings without CF who share similar genetic background and live in the same home environment. In association with the first study that was launched in 2012 at 6 study sites at the US, we added a gut microbiome study in 2015 and a sibling sub-study in 2017. The objectives of our initial analysis are to characterize how gut microbiome and intestinal inflammation evolved with age during the first 6 years of life in comparison with their siblings without CF. In addition, we also examine 2 factors that may influence gut microbiome and intestinal inflammation, namely the CF gastrointestinal phenotypes and breastfeeding. The first cohort includes 183 infants born during 2012 to 2017. Among them, 163 are enrolled in a gut microbiome study, and 56 of these subjects have an older non-CF sibling that agreed to participate in the sibling sub-study. The results I'm presenting today included over 600 fecal samples analyzed for gut microbiome composition using the 16S rRNA method, and 478 fecal samples analyzed for intestinal inflammation using fecal calprotectin. For the CF sibling comparison, data from 41 CF sibling pairs totaling 99 CF samples and 57 sibling samples presented. Regarding gut microbiome characteristics, our initial analysis examined two types of parameters, namely the relative abundance of microbes at taxonomic ranks of the phylum and genus level, and an overall microbiome diversity indicator called Shannon index, which is calculated based on the richness, that is, the number of genera present in the fecal sample, as well as evenness, that is, the percentage of each genus present in the fecal sample. The higher the Shannon index, the more diverse gut microbiome is in that fecal sample. For intestinal inflammation, we measure fecal calprotectin, which is the most commonly used biomarker in the clinical setting. Normal fecal calprotectin is defined as not detectable or below 50. Between 50 and 120 is borderline, and greater than 120 is abnormal. Now let's switch to the results. In this slide, you will see the relative abundance of the 4 major phyla in children with CF from age 3 months to 6 years of age. As you can see, firmicutes, represented in blue, increased progressively from 3 months to 2 years of age. And at the same time, the actinobacteria in purple and the proteobacteria in blue decreased. The 4th major phylum, Bacteroidetes, was very little in infancy, less than 2% prior to 12 months of age, but then quickly increased to about 15% at 3 years of age. We also noted that these 4 phyla distributions became more stable at age 3 years, which is consistent with findings from the general population. When we compare the phyla distributions between the CF sample and the non-CF sibling sample, we noted that there are substantial differences. Overall, CF samples contain more firmicutes in green and less Bacteroidetes and Proteobacteria. However, these differences vary with age. In terms of the overall microbiome diversity, this slide shows the Shannon index in children with CF from age 3 months to 6 years of age. As you can see, in children with CF, Shannon index increased from 3 months to 2 years of age and then plateaued after that. However, their gut microbiome diversity shown in the left panel in purple bars are significantly lower than their siblings shown on the right. Now let's look at intestinal inflammation biomarker. In this slide, you can see that fecal calprotectin in most children with CF was borderline to abnormal. However, these levels did not change significantly with age. On the other hand, their levels from children with CF were significantly higher than their siblings' levels, shown in the middle panel here. These results are consistent with the prevalence of abnormal fecal calprotectin shown on the right-hand side panel. As you can see that more than half of the CF samples have borderline or abnormal fecal calprotectin, which is 3 times higher than their non-CF siblings. We also examined the relationship between gut microbiome diversity and fecal calprotectin levels within the CF population. And we noted that Shannon index, the microbiome diversity indicator, was the lowest in samples with calprotectin that are lowest not detected in the left-hand side bar here, compared to fecal samples that have higher calprotectin levels. The last 2 slides I will show you are the data related to gastrointestinal phenotype and breastfeeding within the CF population. In this slide, you can see that we compare Shannon index and calprotectin among the 3 phenotypes: meconium ileus, pancreatic insufficiency, and pancreatic insufficiency. You can see that Shannon index is lower, meaning lower gut microbiome diversity in MI and PI compared to PS. While calprotectin level was also higher, the prevalence of abnormal and borderline calprotectin was higher in MI and PI compared to PS. Lastly, this slide represents the exclusive breastfeeding by duration here from 0 to 6 months of age. The left-hand side showing the relative abundance of bifidobacterium. We noted that exclusive breastfeeding greater than 3 months was associated with a higher abundance of bifidobacterium compared to shorter duration or no breastfeeding. However, we did not notice any statistical significance in calprotectin level, namely the prevalence of abnormal or borderline levels by breastfeeding. In conclusion, data from our initial analysis show that in children with CF, they had lower fecal microbiome diversity and higher intestinal inflammation compared to their siblings without CF, living in the same home environment. Compared to pancreatic sufficiency, meconium ileus and pancreatic insufficiency were associated with reduced gut microbiome diversity and increased intestinal inflammation. Exclusive breastfeeding longer than 3 months were associated with more bifidobacterium compared to shorter duration of breastfeeding. However, I would like to point out that these results are descriptive and represent work in progress. We will perform comprehensive multivariate analysis when the entire first cohort reached 6 years of age in 2023. With this, I would like to close my presentation with sincere thanks to our study sites, the co-investigators, the research coordinators, as well as the dietitians, and our participant families who have supported the first study for nearly a decade. Thank you very much.
Thank you. Very, very interesting stuff. Do you predict that GI inflammation will increase as these children with CF age?
That's a very good question. I think some children will, but I don't think all of them will. And we will find out when we have all the data from the entire cohort.
Do you feel the higher incidence of CF babies being on proton pump inhibitors and or antibiotics could be affecting the gut microbiome?
Absolutely. And in fact, that's our initial design of the study, that those 2 factors are the ones that we are most interested in finding out, and especially with the PPIs. I think there are more studies looking at the antibiotic effects on microbiome. And those studies from other populations demonstrated, very clear effect from the antibiotics. With the PPIs, there are fewer studies, and in CF, especially in the first cohort, we found that infants were put on PPIs very early in life and often very long period of time. However, these medications are given repeatedly or intermittently, and they're longitudinal. So therefore, we really have not looked at these longitudinal factors yet, which actually will be very interesting to analyze later.
Yeah. Do you control for, are any of these children on supplemental probiotics?
Very good question. Yes, actually a lot of them. And most of them were put on probiotics during antibiotic therapy. However, a substantial proportion of them also stay on probiotics. And that's another factor we're very interested in. And we're looking at probiotics also concurrent with the dietary intakes. We have the dietary data, which by itself is quite complicated to evaluate. But it would be very nice to look at all of these factors together in terms of their influences on gut microbiome and fecal calprotectin.
Yeah. Did you control for food intolerance in this study?
Good question. We of course have not in these analysis. However, in our nutrition interval history questionnaire that we collect at every CF center visit, we do have questions on food allergy and intolerances. So we would be able to somehow incorporate that into the analysis in a limited fashion.
Okay. Do you have any residual samples where metagenomic analysis could be undertaken?
Very good question. Yes, we do. We, these are fecal samples, so we're lucky that we do have a fairly good amount of most of the samples, and metagenomics are more expensive. So we're hoping to find out some clear findings and see if we can select some a subset of samples for metagenomic analysis.
Do you have any ideas how we could improve inflammation in CF patients?
Wow, that's a big question.
It is a very big question.
I think until we find out whether these inflammation, how long they're present, and if they affect significantly some other important clinical outcomes, then we can start to think about when and how, maybe to intervene. I don't think I will be able to provide any insight on that to our audience at this point.
Yes, well, thank you very much. We will certainly look forward to more results from your study.
Thank you.
And now I'd like to introduce our next and final speaker, Dr. Meghna Sathe is a pediatric gastroenterologist and co-CF Center Director at UT Southwestern Children's Health in Dallas, Texas. She is also both a previous Digest awardee and a current clinical research scholar, program awardee. Today, she will present her work as co-PI on the GALAXY study in describing the experience of utilizing electronic patient-reported outcome measures in CF gastrointestinal disease. Dr. Sathe?
Thank you so much for having me here today. Thank you everyone for coming to my talk on the utilization of electronic patient-reported outcome measures in cystic fibrosis research, application of the GALAXY study. I'm proud to present the results of the study on behalf of Drs. Freeman and Moshier and the whole GALAXY study team. Here is my grant funding and my disclosures. Today's medical environment emphasizes co-production in both clinical care and in research. So what exactly is co-production? Co-production, as defined by BMJ Quality and Safety, is the idea of leveraging professional and user collaboration to support a patient's proactive management of their care. This is especially important in chronic care, in which patients and families can be empowered to reduce both the burden of illness and treatment. The goal is to co-create value with their care team that takes into consideration both health and well-being. The James Lind Alliance focuses on extending this idea of co-production into research by encouraging collaboration between patients, families, clinicians, and researchers in identifying research priorities. The CF Foundation has created a community of persons with CF and caregivers called Community Voice to elicit feedback on a variety of important clinical questions, including the design of research. Active involvement of patients and families in both design and execution of research importantly contributes to both the improvement of the quality of research and ultimately everyone's goal, improving the quality of care. This idea of co-production has been captured in clinical research with the utilization of patient-reported outcome measures, or PROMs. PROMs are standardized and validated questionnaires that directly measure patients' and caregivers' views on their health and quality of life. PROMs can be utilized in clinical trials to assess the effectiveness of treatment, as well as to assess the burden of treatment. In fact, PROMs are now considered an essential part of clinical research. Use of PROMs is vital in the approval of new drugs and new indications for existing drugs by the FDA. The Galaxy study utilized a collection of PROMs to evaluate the prevalence of gastrointestinal symptoms in persons with CF. These PROMs were provided to study participants electronically to be filled out at specific intervals over the course of 4 weeks, with only pre-programmed electronic reminders. So why use electronic PROMs? Electronic PROMs, or EPROMs, allow for research participants to engage in clinical research in the outside of clinic environment. EPROMs empower research participants to have more control of how and when they engage in clinical research. EPROMs also allow for minimization of research coordinator resources. This has been especially important to consider during the current COVID pandemic, in which clinical research efforts have been drastically impacted. Let's look briefly at the impact of COVID on a local and national level. Studies were temporarily halted during the shutdown, and even now enrollment continues to be challenging due to a combination of in-person and virtual healthcare options. Our own center had 12 studies impacted, our adult center 19, 70 centers within our Department of Pediatrics here at UT Southwestern, and 32 studies within the TDN. The primary aim of the Galaxy study was to evaluate the feasibility of utilizing EPROMs with minimal research coordinator involvement in the outside of clinic environment to collect important research data. The hypothesis focused around identifying a set of EPROMs that would best characterize GI symptoms outside of exocrine pancreatic insufficiency in persons with CF. As there was no intervention in this initial study, our hypothesis was that without intervention, there should be minimal variability of GI symptomatology in persons with CF within a 1-month period of time. Participants were eligible for the study if they were greater than 2 years of age and had a smartphone or tablet capable of downloading the app. 3 validated GI PROMs and 1 stool-specific questionnaire were administered electronically in a prospective fashion across 26 TDN centers at baseline and then outside of the clinic at weeks 1, 2, and 4. Reminders were only provided by the mobile application. EPROMs expired if not completed within 24 hours of the expected date to ensure data was collected appropriately within the study window. Before starting with the results, we would like to thank the 26 sites that participated for completing enrollment of 400 subjects in a period of 4 months. For those of you who are unaware, our study fully enrolled and was closed almost 1 year earlier than anticipated. Graphics demonstrated a similarity to the CF registry as noted here, with similar distribution of males and females, genotype, and pancreatic insufficiency status. We had a slightly higher male predominance. The majority of participants were Delta 508 homozygous at 54%, followed by Delta F508 heterozygotes at 35% and other at 11%. The majority of participants were pancreatic insufficient at 89%. Age distribution was purposely aimed to capture 60% adults and 40% pediatric participants to reflect the growing adult CF population. As participants completed the first EPROM at enrollment in clinic, baseline for completing 1 EPROM was 100% and around 98% for completing all 4. There did seem to be a consistent decrease in filling out EPROMs in the outside of clinic environment with each week for all participants. However, feasibility was still proven by the fact that overall 77% of participants less than 18 and 83% of participants greater than or equal to 18 completed at least one EPROM. 72% of participants less than 18 and 82% of participants greater than equal to 18 completed all EPROMs. It is noted that due to the rapidity of enrollment in the beginning, there were some technical difficulties with the functionality of the app that could have contributed to the lower completion rate in the beginning. We suspect that differences between younger and older age groups is based on caregivers' need to fill out the surveys. Whether this was due to their inability to understand or interpret the question for the minor, or whether they simply forgot, was not differentiated. Scores did not vary substantially by week for any of the PROMs, which shows sustainability and appropriate lack of variability in an observational study of GI symptoms without intervention. Now, just to remind you, as Sarah Jane had mentioned in her talk, the PAC-SIM focused on lower GI symptoms, the PAGI-SIM on upper GI symptoms, and the PAC-QOL focused on the quality of life due to constipation, including both physical and psychological discomfort, as well as overall dissatisfaction. Similar results were noted for the stool-specific questionnaire with minimal variability week to week without any specific intervention. Here we had created a supplemental questionnaire addressing questions about constipation symptomatology we felt was important to assess from the participants, but was missing in the validated PROMs. We assessed bowel frequency, pattern, consistency, and stool leakage. It is interesting to note that stool leakage was identified at 6 to 9%. We also asked participants simply if they felt constipated. The results of the Galaxy study showed the feasibility of using EPROMs to collect time-sensitive data consistently within a narrow window in the outside of clinic environment is possible. The reliability of the selected EPROMs was proven with minimal variability observed between baseline and weeks 1, 2, and 4 in this observational study of GI symptomatology in persons with CF. Use of EPROMs should be both feasible and reliable in an interventional study aimed to improve GI symptomatology. In conclusion, utilization of EPROMs is feasible, reproducible, and sustainable in an observational study of a population representative of the CF registry in evaluating baseline GI symptoms over a 4-week period in persons with CF. EPROMs decrease the burden on persons with CF participating in clinical research by allowing for data collection in the outside of clinic environment. EPROMs maximize research coordinator time and efficiency with the use of electronic reminders. It is timely to think of utilization of EPROMs in the outside of clinic environment as clinical research struggles to venture forward in the backdrop of a global pandemic. It is virtually impossible to conduct studies at the same rate with the same efficiency as in the pre-COVID era. Finally, we would like to give a special thanks to the Galaxy team at the TDNCC, CFF, and all our participating investigators and research coordinators, and especially to our patients and families who allowed us to develop this project with them from the very beginning through their input from community voice and then through participation in the actual study. Please visit posters 213, 227, and 216 for more Galaxy results, as well as the plenary. Thank you.
Thank you very much. Would use of an EPROM exclude families from a lower socioeconomic status, do you believe?
So in this study, we did not provide a device. However, in future studies that has been considered so that we do not exclude patients with from lower socioeconomics.
And why did you not use a validated CPROM such as the recently validated CF abdomen score?
So the CF abdomen score was actually not available when we designed this study. Gen abdomen was available. However, we did want to include some qualitative data as well. So we wanted to ask about how they felt constipation, and that wasn't included in it.
Okay.
Those were added actually in CF abdomen.
Interesting to see the abstract on constipation being underreported using EPROMs. Do you feel any GI symptoms may be overreported?
I don't think any were overreported. However, we were surprised that one of the highest prevalence of symptoms, in addition to constipation, were bloating and distension, lower abdominal pain, and stomach fullness. So we weren't really expecting that. We were expecting constipation to be the highest, but we were surprised when we saw that.
Did you get any feedback on the suitability of using these questionnaires in young children?
So during our initial evaluation of which EPROMs to use or PROMs to use, we did have a good distribution of parents in community voice, and we used that data to select the PROMs. So we felt pretty confident about utilizing them in the actual Galaxy study.
And were any instructions given to parents on how to elicit symptoms?
So initially, we didn't give any instructions for the research coordinators to specifically go over how to elicit the questions or the answers from the children. We did have enrollment done when they filled out the first EPROMs was when they enrolled, and that was with the research coordinator usually with them, so we could make sure that they knew how to use the app and to kind of get through all the questions. But that's a good suggestion in the future.
Yes. Did you ask about compliance of PERT?
We did not. We were actually really focused on non-pancreatic enzyme symptoms, so we did not ask about the compliance of PERT. We did gather what medications they were at the beginning of the study at enrollment.
Okay. What are the next steps for EPROMs in CF research? And given the pandemic, do you feel this may be happening sooner?
So as Sarah Jane alluded to, the Galaxy EPROMs have been used in PROMISE. And so that's where they are right now. We're hoping with our results that we can design some studies that actually look at interventions to improve the symptoms that we found to be prevalent.
Okay, I think that's all of our questions for now. Thank you, all of our presenters today, for doing an excellent job. And thank you, everyone, for attending the session, and to the CF Foundation. Goodbye, everyone.